Sir, we can start.
Good evening to all. This is Chandramohan, ortho physiotherapist from Sri Samraj Physiotherapy Center, Vadivelan, Tamil Nadu. A warm welcome to all for the EXRX India's and Sri Samraj Health Services Private Limited's presenting Webathon, a web series enthusing for the world record in the field of physiotherapy, not just counting the topics, but responsibly providing the knowledge for the physiotherapists in India and more than 20 other countries. Apart from this, EXRX India is providing online OG consultation for the women's health related issues in association with Dr. Rupesh, Peak Health Studio, Chennai, Dusa Creations, West Bengal, and it is powered by Fitness and Rehab India YouTube channel. Today's EXRX India's topic is fear of fall in geriatric population will be presented by Dr. Vadivelan Sundaramurthi, MPT, and he is a PhD scholar in Tamil Nadu Sports University. He's a physiotherapist from Kadalur, and I would like to welcome EXRX India team members, Dr. Rupesh and Professor Duna now. And also now I'm welcoming our resource person, Dr. Vadivelan Sundaramurthi, and request him to commence the session. Please, sir.
Very good evening to one and all. So I'm happy to be here. It's the second time with the EXRX India, sir, for inviting. Actually, I'm very happy, and I render my thanks to Dr. Chandramohan sir for inviting me again this program. So I have been here. I have been because of Dr. Mohana Krishnan, who is working as a physiotherapist in Jibner. So through him only, actually, I came to know Dr. Chandramohan sir, and I am aware of the EXRX India. There's a very good work. Actually, it's keep continuing doing a one topic as itself is very difficult to do a webinar on one topic, but it's a continuous series. Actually, I think this is the second series is going on. Almost 42 topics, I think, if I'm right. So this is very hard and dedication towards the team EXRX India. So actually, I'm from my heart. I wish him to be the great success in future, to continue this work to be continued for enriching knowledge of a therapist. So it's a highly it's a non. It's non. There is no money in playing in this one. So this is highly service oriented. So I wish team EXRX would be continue this work in future. I wish all the success in future. So I am Vadivelan Sundaramurthi, a physiotherapist, sports physiotherapist from Kadalur. So today I'm going to present fear of fall in a geriatric population. So shall I share the screen, sir?
Yes, sir, please.
Okay. So we are the physiotherapists mainly treating old people. So actually, I had a patient. So more than this, her age is around 65, who came to my clinic with right knee pain. So have been have examined her, and so came to know this is maybe osteoarthritic changes in her right knee. So I have started my treatment. So while the treatment is ongoing, she asked me, she raised a question. So why my right knee is paining? So this wise lady asked me why my right knee is paining. So as her age is around 65, so I blankly says, so due to your age, so this is a kind of degenerative changes in your joint. So due to your age, so might be the reason for your right knee pain. So she's so wise, okay. So immediately she raises another question. So is it only my right knee is getting aged? So is it only my right knee is getting aged? So my left knee is still young. So it's not getting older. So you mean to say only my right knee is getting aged? So this wise question make me to think more. So we might be, as a therapist, we might be answered this one. But this topic is going to give brief details about why the osteoarthritis changes, why the pain. So this is why the pain only on her right knee. So this topic may be one of the evidence, or one of the proof that why only the right knee, or only a single side unilateral knee pain in older age people. So here the osteoarthritis is not only because of aging. Actually, there might be a lot of reason behind in it. So we can see into the topic. We might be understanding what would be the reason for degenerative changes in single side of knee, and how it's contributing fall in older people. So definition of a fall. So an event result in a person coming to rest inadvertently on the floor, often caused by multifactorial risk factors, including both intrinsic and eccentric factors. As is actually the person fall inadvertently on the floor, as mean the person has been fall down. That's the definition for the fall. So we all know the aging as an irreversible normal phenomena, is an irreversible normal phenomena that take place at the molecular level. So reflecting not only physically, actually this changes is not going to reflect only physically, is also the person functional and psychosocial component is also getting involved. So it's irreversible changes, and it's happening at the molecular level. So the point of perception is we have about how we can manage the aging and the consequence of aging problems. The fall reported global fall reported, actually the 1 in 4 older adult reported fall globally, especially in 2004. 4,24,000 fall related death happened globally. In 2004, as a 4,24,000 fall related deaths happened globally. The very sad news is 1/5 of them took place in India. So actually, so in this population, the 1/5 of them took place in India. So one in every second, one older adult is getting fall. According to the World Health Organization global report on fall prevalence states that 28% to 35% older adult more than 65 years fall in each year. So 28% to 35%. In India, especially, the prevalence rate is about 14% to 53%. So in the today topic, actually, we have a 5 major objective. So the first objective is we are going to define the problem of falls. First, what are the problems due to falls? We are going to define the problems. And second major objective is delineating the multiple interacting factors in the falls. Actually, delineating multiple interacting. What are the interacting factors in falls? We are going to delineate those factors. And the role of partial control in instability. So how the partial control, what's the role of its partial control during instability? That is the major, we are going to see as a third objective of today's topic. And the fourth objective is strategy for comprehensive assessment. We are going to make a strategy for the comprehensive assessment. According to the assessment, we are going to find principles of intervention. So these are the major 5 objectives we are going to look into this topic today. The first objective is the problem of fall. The fall is the second leading cause for unintentional injury morbidity. Especially there's a second major causes, the falls, accounting for 11% unintentional injury mortality rate globally. So actually the person is getting as a second leading cause for a disease, and 11% unintentional injury mortality rate, as death rate, as a globally reported in globally. The India is second most populated country in this world. In 2011 census in India has been stated that the percentage of older adult above age 60 is 8.6. In India, the percentage of older adult above 60 is 8.6 in total population in 2011. And this population is like to get increased to 198 million in 2030. And this population is going to increase about 198 million people. And it means that 198 million people would be older adult in 2030. So this demographic transition says there is an absolute increase in older adult population. Okay, the older adult population is going to increase by year by year, and 2030 is almost there are 198 million people. Okay, so there might be an increased demand on our healthcare system. This demographic transition will give a increase the demand on healthcare system. We are a part of healthcare system, so we are also facing the demand. So this demand, what would be the demand for us to add the quality of, actually as the older age people is going to increase, so we have to, as the healthcare system, as a part of healthcare system, we are going to add the quality of life to years lived. So whatever the age they live in, so we are the therapists are going to give a quality of life to them. So it's not a life, it's a matter of quality of life, how quality they lead their life until their end. So that's the therapist decide. So usually we say physician add years to life. As we are the therapists, we add a quality of life to years. Okay, so we are the major health professional who is going to give a quality of life to the older people. Um, So fall and its consequence may also actually, once the fall has been happened, it may be a traumatic or non-traumatic. Okay, so fall might be with trauma or without trauma. Even the fall without trauma has a negative impact of the person, a negative impact to the person. Okay, so negative impact, once they fall, they may have a fear of fall by falling again. So விழுந்துருவோமோ திருப்பி ஒரு பயம் வந்து ஒரு தடவை விழுந்துட்டாலே வந்துடும். So once they fall down and they have a fear of fall, then they have a negative impact that leads to post-fall syndrome. Post-fall syndrome is nothing but so they lose their confidence, the dependency. They are independent usually before fall. Once they fall, the dependency and the loss of autonomy, confusion, immobilization, and depression. These all the post-fall syndrome once the fall has been happened in older age, which will engender the further restriction of daily activities. These all problems will combine together and further restriction of their daily activities of all people. Overall, fall contribute to increase the risk of further fall. Once they fell down, that fall contribute to increase the risk of future falls. Okay, so we can't say the person has fall down, we can treat it, it's over. We can't say this is all right, because once they fall, they have a post-fall syndrome. They have a chances of falling again. So once this fear of fall is with the older people, that's definitely going to affect the quality of life of the person. Okay, so the fall and consequences have a major role in the quality of life. So once the older people quality of life is affected, they become dependent. Dependent means but they have to depend that blood relation for the daily needs, the ideal activities, or maybe functional activities. They have to depend that blood relation. So once the dependency has happened, there might be a reason for negligence. In the urban culture, the both husband and wife is working culture. In working culture, so they don't have a time for to taken care of the parents. Until they are independent, they can do their daily activities without any problem. So once the quality of life is affected, they have to depend others. So once this the reason might be the negligence from the blood relation. So once the negligence happen, that might be the one of the reason why the old age home is getting an increase in our country. So So the single fall, so the one single fall is due to, so one highly independent old adult become dependent in a single fall. So we all know, maybe as a therapist, we come across an older, one of the complication of fall is the fracture of proximal femur. So maybe till the fall, till this condition, the older adult, maybe a very active person, once they fall down, if they get fracture in the proximal femur, so the conservative management fail due to avascular necrosis. So there is avascular necrosis, so there is a less chances for conservative management to manage the proximal femur. So they have landed in surgery. So once they have landed in the surgery, so usually the older age people have a comorbidities like hypertension, diabetes. Okay, so this comorbidities may prolong the recovery after surgery. So definitely after surgery, this comorbidity has a role that the recovery might be prolonged, or recovery may not be happen. Okay, so that increase the risk of post-operative morbidity and mortality. So there is a chance of increasing, because of the comorbidities, there is a chances of increasing the risk of post-operative morbidity, and they may be become a disease, they may be bedridden, or due to lack of movement, that might be there might be a loss of their life. So there is a lot of risk in the post-operative morbidity and mortality. So the single, actually, what I'm coming to say is the active person, so the highly active older people may get a bedridden patient with single fall. So here the falls perspective, falls and the prevention of fall perspective needs to be widened. So according to the US Public Health Service has estimated, two-thirds of the death due to falls are preventable. We can prevent it. We can manage it and we can prevent it. Two-thirds of the death due to the falls are preventable. So that's why WHO proposed active aging, which aim improving quality of life for all people they age. So, so the WHO formed the active aging policy framework in 2002 that says the aging should be active. So it should be active. The older people, once they age, so they should be active. Aging is a process of optimizing opportunity for health, participation, security, in order to enhance the quality of life. Active aging is nothing but a process of optimizing opportunity for health and the older age participation, security, in order to enhance the quality of life as the people age. So they should be active once they get age. So that's the proposal of World Health Organization in 2002. Health can only be created, sustained. Health can be only created and sustained through the participation of multiple sector. So single sector can't deal with health. So, so as the rehabilitation team, so the multiple sectors as a contribution towards the health, it suggests that the health provider and professional must set a goal. Actually, we are the health professional. We must set a goal that will make a healthy older person to remain a resource to their family and community. So we have to be, we set a goal when we treat a geriatric patient that will make a healthy older person to remain. They are a resource to the family. They are a resource to their family, not only a resource to the family and as well as the community. So finally, the problem in India, actually, in 2002, the older 60, the 60 population, as I said, is in India, 81 million people above age of 60. In 2025, is going to be 168.5 million in 2025. So there is a lot of the need towards achieving quality of life to these many peoples. So in this respect, perspective of falls needs to be widened in view of preventing fall. Okay, so widen, how it's widened. So need of preventing the fall, how we prevent. So we can identification and management the risk factor of falls. So we have to identify what are the risk factor which contributing fall, And we have to give a proper rehabilitation program intervention towards the management of risk factor. That is the major portion to prevent a fall and its consequence. So we completed the first objective. We have defined the problem of falls. Then we knew the delineating the multiple interacting factor which contribute falls. So we have a major 4 area. So one is ecological input, and second one is the functional input, and third one is biomedical input, and the fourth one is the physiological input. Ecological input is nothing but is eccentric factor which contribute for falls. Eccentric component, okay, what are the eccentric component? As maybe unusual, different environment factor, which is coming under the ecological input. So how we decide the person's severity when they fall in the different environment? For example, if the person with impairment fall unusual environment, we may decide that the person may have a minimal impairment. For example, a slippery surface. When the person is slippery, everyone can fall, have a chance of fall in the slippery surface. So that might be the minimal impairment. So it in case if the person with unfamiliar territory, not at home, so outside the home, it's not a slippery surface, unfamiliar territory. If they fall with the unfamiliar territory, that may we can decide the person may affected mildly with fear of fall. And third one is the person is a known environment, is walking in the home. If he fall down, we can think of the person impairment would be severely affected. So these are the factors contribute ecological, this especially environment. Actually, I'm not going to deal with much about environmental factor or biomedical. So I'm going to deal only major factor about the physiological factor, which we deal with. So musculoskeletal problem is coming under the physiological factor. Just to know, so this ecological input is nothing but eccentric component of factors which related to falls. Then the biomedical input. So here, this is the medical events, all the medical events which reason for fall. So we have acute and chronic diseases. So acute diseases, electrolyte abnormalities, infection, drug side effect, dehydration, orthostatic hypertension. In the chronic disease, we have a cardiovascular condition like arrhythmia, neuromuscular disease like a stroke, Parkinson, and vestibular disease. These are all coming under the biomedical input. And the functional input, so identifying important routine movement, so which movement the person is having fall, maybe so walking on the morning time, so getting ready for work, so during that time, so those which functional movement is the reason for fall is nothing but identifying a functional input. So physiological input, actually the major part of our physio is in the physiological input. So identification and deficit in postural control. What are the contributing to instability? So component is nothing but a sensory. We are going to deal with the postural control. All this sensory and central processing. Effector is nothing but a strength, a muscular strength, a range of motion, biomechanical alignment, and flexibility. These all coming under the physiological input. We are going to deal majorly with these factors. So we have delineated, this is the second objective, we have completed the delineating the multiple interacting factors. And the third one is the role of postural control in instability. So the postural control is nothing but whenever we lose the balance. So as when we fall, okay, the body is trying to regain our balance with how the adequate postural controls required through postural controls. Okay, so the adequate postural control requires keep the center of gravity over the base of support. So the person when trying to fall, they're trying to keep the center of gravity over the base of support during a both static or dynamic situation. When the static is standing, or in the dynamic, even walking or movement, the person whenever they lose the center of gravity is away from the base of support, they're trying to hold the center of gravity over the base of support. That is the postural controls. So how it's happened? We have a sensory input. So it's the three major sensory input. One is the vestibular system. And the second one is the visual system, and third one is the proprioception. The vestibular system mainly contributes to the head alignment. So the mainly contribute the head alignment, and the visual system keeping the eye movement, and the proprioception information is information from joint and the ligaments, which relatively inform that the segmental movement with each other. So the main system, the main major three system sensory input from these three systems has been integrated to the central nervous system, that is with the cortical center. The cerebellum coordinate and regulate the postural movement and balance. The cerebral cortex actually, due to the previous response, the cerebral cortex is making decision-making thing, that how the person is trying to get balance immediately according to the previous experience. The brainstem integrated and sought the sensory information, and these all information has been coming as a motor output. That output make a partial adjustment and we regain a balance. So once we lose the balance, this information, sensory input, will give all this information to the central nervous system, and the central nervous system process, and through motor impulses, the partial adjustment has been taken, we regain our balance. This is the partial control when there is the instability. So actually in the partial control, there are three major variables. One is the center of gravity, the another one is the base of support, and the last one is the line of gravity. So the center of actually we may come across this type of event when we do our school. So balancing a ruler in our finger, so rolling book on our finger. So these all doesn't know that this is only this mean that center of gravity. Okay, so the human body also has a center of gravity, so which should be within the base of support. So for example, irregular objects, the center of gravity can be identified through plumb lines. So the plumb line has been drawn with the two corners, and where the two plumb lines intersect is a center of gravity of irregular object. So once we hang this irregular object here, so it should be horizontal. So this is what the center of gravity for object. So the base of support. So the base of support is actually we have this is the pointed base of support. So we can see the ball. Once we displace the ball keeps rolling, keeps on rolling. So because the base of support is a pointed one. So you can't, if you give a same force to the table will not move like a ball because it's a wider base. So the wider base give a more stable, the wider bases are more stable, but the pointed base is a high mobile. Okay. So when we look into the fall, once the older age person fall, they immediately they can support their hands on the floor to increase the base of support. So that's bring backing the center of gravity within the base, so they can avoid the further fall. So that's why. So the table support, the table is more stable than the ball, but here the humans are not only a stable. Okay, so they are mobile as well as stable. So here the two components should be taken care. So if you give a wider base of support with a walker or can, so that is the lack of mobility. There is not lack of, there is a slowness movement because you are increasing your wider base. So definitely the movement would be slow, getting slow. So at the same time, if you're not giving a proper support, that may lead a further fall. So the line of gravity. So the line of gravity, whenever the movement is more focused, shifting the line of gravity away from the base of support will produce instability. But however, they are more mobile. So the center of gravity falls nearly away from nearly the base of support. So they are more mobile. They have a chances for increasing mobility. So if it is within the base of support, if the line of gravity falls within the base of support, they are more stable. So actually, we have a simple mechanism to know the center of gravity. So for example, any image or any diagram, actually, if you draw the line which is connecting all its border, and if you draw a line diagonally, the two line where it's get intersect as a center of gravity. So we can follow the same manner for other diagrams. Okay. So these are the different posture actually with the knee flex position. So this person is trying to fall down, and this is the yogic chakrasana. So these are the different position we can find with the center of gravity with the line which connect the border of the diagram. So here you see the center of gravity is almost near to the abdomen. The person is more stable, and comparative to the previous one, the knee flex, the center of gravity is a little bit lower than the previous one. So if you compare these two, the second one is more stable than the first one. Here, the center of gravity lies away from the body, away from the baseline. So this person is the lack of stability. So the internal system will help him to regain a balance. So here, the center of gravity is away from the body. However, the center of gravity line is within the base of support. So we can consider this person is more stable. So coming to the base of support, so here all the line of gravity is falling in between the base of support. Only this diagram insists that the line of gravity is away, a little bit away from the base of support. So here, this person we can consider as unstable with all three positions. This position is considered, this person is going to fall when we compare with all three position. When we come in, so again with line of gravity, how we classified, how we say the person is more stable. So with four major things. One, the weight of the object. So the stability decided by the weight of the object. The heavy weight is more stable. Okay. And the second one is the size of the base of support. So here the size of base of support is more. The base of support here, there's the object A has a more size, more base of support comparatively to base. So the wider base of support are more stable. The height of the center of gravity. So where the center of gravity lies, the height. So the lower height is more stable. When we compare, actually the B has the more height. So if you look into the height, the B has more than the A. The A is, the lower height is considered as a more stable. And the location of force of gravity vector. So it should lies in between the base of support. The vector actually from the center of gravity. If you draw a line, so this should lies in between the base of the more its center is considered as more stable. Okay. So here the four major variables decide which object is stable. So we can think that if the person losing a balance, for example, older people losing a balance, definitely they are going to sit. So they are lowering the center of gravity and they are trying to regain the balance. So that's why as if the second principle applies. So the third principle applies. So lower center of gravity has a more stable and the size base of support. You think actually the person, whenever he loses balance, he can step into one step. He can increase a base. He or she increases the base so to regain a balance. So the wider base give a more stable. So wider base, when you think of wider base, again is a wider base is stable, but it will not, the mobility point of view, it will not give a good mobility. So the stability is okay. But once you want a mobile, it's again is a narrow base of support is highly mobile than the wider base. So these all things actually, so that's why actually the person whenever fall, they support their hands to increase the base of support and bring back the center of gravity within the base of support. So we have seen the postural response, the automatic postural response whenever we lose balance. As I told you, the visual, vestibular, somatosensory system process it and previously with a previously learned response, and execute a corrective automatic postural response. So whenever we lose balance, these three systems will contribute to sensory input, and the central processing system will handle it and with a previous learned response and give a correct motor response to regain a balance. So there's actually automatic postural response is completely a transcortical response. Actually, it's a completely higher central response. Usually it has a latency of 100 to 120 milliseconds. So long loop reflex, usually it has a latency of 100 to 120 milliseconds. So this may delay when they get age. So that's the reason the fear of fall, due to the late response, the fall happen more on older people. Usually the stretch reflex is a monosynaptic reflex only having a latency of 50 milliseconds. So when we compare to the voluntary movement, the latency about 150 milliseconds, because mediated as a voluntary movement or mediated by the cerebellum. So it has a latency of 150 milliseconds. So in the balance control, we have a two type of situation. One is the feedback situation. Another one is the feed forward situation. So feedback situation that we know that once we slip, we try to fall. So there's a center of gravity is displaced and the CNS based. So CNS has been trying to regain the balance. So this is a feedback system from the central nervous system. It's the same thing as a feed forward situation. For example, if you try to catch the position, if you try to catch the ball, so before the voluntary movement, the automatic postural response systems as engaging this anticipation. We are going to, there is anticipation of trying to catching the ball. So there's definitely the balance system has been activated before the voluntary movement. So that's just the feed forward situation. So we know that we need a balance. So the balancing system is activated before the voluntary movement happens. So the postural response research has been conducted, and the older people has been perturbated on the wobble board. Forward, backward, and rotatory response has been validated. So in this three thing, actually, we have a basic strategy. They have formulated, research has been formulated 3 basic strategy when happening when the subject is regaining balance. So when the balance is disturbed, actually they have measured 2 things. One is the time for the muscle response, that is the latency. That what is the time time taken to muscle respond when we lose balance, and the sequence, which muscle has been fired first and which muscle has been fired next. Actually, the sequence of muscle pattern also been taken for consideration through EMG. So this has been measured by EMG. According to this research thing, actually they have found 3 major strategies happening whenever there is a lack of balance, when the person is trying to regain a balance. The 3 basic strategy. One is ankle strategy, and the hip strategy, and stepping strategy. So ankle strategy, actually, for example, think of moving on the bus. Actually, you are standing on moving bus. Okay, if the bus started to move, actually you are standing steadily, and your body is getting sway front and back to maintain your balance. So the initial things. Okay, so if the driver increases speed or decreases speed, so the sway is not only enough to maintain your balance. So that time, what will happen? Your body is going to bend forward or lean backward to maintain your balance. That's the second strategy. And third one is when the driver apply brake. Okay, when the driver applies brake, so that time, so these strategy will not help help to regain a balance. Then you think that you may have a step forward or step backward to regain your balance. These are the three major things happen even when the subjects are getting perturbated. So the first one is the sway is nothing but the angle strategy, and when you bend forward and if you regain balance, that's a hip strategy. When you step forward and if you regain a balance, it's called a stepping strategy. These are the three major strategy whenever the balance is getting disturbed. Happening to regain these strategies are happening to regain a balance when the subject is out of control. So what's the concept of ankle strategy? So when there is a relatively small disturbance on the base of support, so there is a small disturbance on the base of support. So the angle strategy is helping to regain the balance. The foot acts as a lever to maintain balance. Actually, your foot is stable, so your body foot is act as a lever to maintain a balance, and your body will like an inverted pendulum over your foot. So body is going to sway like front and back inverted pendulum on your foot. So that's the way it can bring back center of gravity within the base of support. So this latency is approximately 100 to 120 seconds. So this happens between 100 to 120 seconds once the balances get disturbed. And the typical muscle sequence is distal to proximal. What is the distal to proximal? Your distal muscle is going to get fired first, followed by proximal muscle. So here the perturbation on the wobble board. The subject is trying to lean forward lean forward and backward. Okay, so when the subject is lean backward, the body is going to act like an inverted pendulum. So the compensatory action from the body is going to lean forward. So your gastrocnemius act first to stabilize your body. Your gastrocnemius act to stabilize the body, followed by your hamstring whenever you sway backward. So as I told you, the body is going to act like an inverted pendulum. When the sway happening on the back side, the body compensatory activity moves forward, and the foot muscles fired, distal muscle fired first. That's a sequence. Distal muscle, that is your gastrocnemius and soleus, fired first, and followed by hamstring. When the body is move forward direction, when the platform move the forward direction, the body has a compensatory activity of moving backside. So your tibialis anterior and fired first, followed with your quadriceps. So this is the ankle strategy, which has distal to proximal muscle firing pattern. So what is the clinical implication of this ankle strategy? Studies say, actually the research says, during quiet stance, sway increases with age. Actually, because of aging, during a quiet stance, the sway increases with age. Have a slower contraction muscle. Actually, when we compare to the normal adult, the older age has a slower contraction of leg muscles. So this will reduce the ankle strategy once we get age, and activate proximal muscle first, followed by distal. Usually the pattern is, when the adult pattern is, the distal muscle is getting activated first, followed by the proximal muscle. But here what's going to happen is, because of the muscle firing pattern changes, the proximal muscle is getting activated first, followed by the distal muscle. And the sway is actually in older people, the co-activation is happening on the older age, it means that agonist and active antagonist muscles get co-activated, and the older people stiffening the joint instead of producing the sway. So that's the main reason for fall on older people. So the co-activation of agonist and antagonist muscle, instead of acting only the agonist or antagonist, both muscles is getting activated and the joint is getting stiffened. That may lead fall in older people. So the third thing is, especially on the older adult, the activating ankle strategy, activating hip strategy instead of ankle strategy. So they, instead of swaying, instead of giving a sway over the foot, the older, whenever they try to fall, they are producing initially the hip flexion instead of ankle sway. The second strategy is hip strategy. So when there is a forceful perturbation, as I told, when the driver increases the speed or decreases the speed, so automatically the body lean forward or lean backward to regain the balance and activating the hip muscle. So when this happens, the perturbation is a little bit forceful. This initial ankle strategy is the perturbation is very minimal. So the ankle strategy, we can maintain a balance with ankle strategy. But when the perturbation is more forceful, but the angle strategy will not help to regain a balance. So that the moment hip strategy will play a role. Okay. So the person may bend forward to bring back the center of gravity, or bend backward to bring back the center of gravity. In this way, actually, in the hip strategy, the muscle pattern is proximal to distal pattern. So here, the proximal to distal means here the lower leg muscles is maybe very minimally active or maybe inactive. So when you bend forward, automatically your erector spine and the glute muscles will going to control your back. So when you lean forward, your hip flexors and the abdominal muscle work first to control, to regain your balance. So what is the role in hip strategy in older adult? Actually, so what is the hip strategy in older adult? Actually, we prefer walker in older, whenever the older people has problem in our leg, whenever the older people has need support. When we usually prefer walker, okay? So when the older people walk with walker, what's happening is actually you can see many times if they walk with walker, they usually not rely on ankle strategy. Usually they bend forward. So for the balance, they rely on their hip strategies. Okay. So once they rely on the hip strategy, the ankle strategy is going to be nil, or they are not going to use their ankle strategy to gain a balance. So this may lead to further decrease in balance. So we think that so giving a walker, we can stabilize the older people with walker. So we can give them more support. They are more balanced. But thing is, if they keep using the walker more than one point of time, so they completely rely on the hip strategy instead of ankle strategy. So the thing is, the muscle surrounding the lower leg going for weakness or a stiffness, because it's going to be a disuse atrophy. They are not using much the lower leg muscles. Okay. So because of this, the pros and cons of walker, actually, I'm not saying that the giving walker is not advisable, but the support of time, actually, whatever the support of time, once the person is capable of walking without without dependency of walker, you have to relieve from the walker and make the person to walk independently, or you can reduce the base of support with the sticks. And the third strategy is the stepping strategy. So when there is a situation, the center of actually the force is more than the moderate level. When the ankle and hip strategy is not able to maintain balance, is not enough to regain a balance, the person may take a step forward or backward to gain a balance, to regaining balance. So that is nothing but a step strategy. Stepping or stumbling strategy is necessary to regain equilibrium, because neither angle or hip strategy is not sufficient. Okay, that on the moment, the step strategy is going to be play a role. So what is happening when become an old adult? What is the strategy in geriatric population? Compared to young people, the older adult initiates stepping strategy in response to small loss of balance. Actually, usually the older people take more steps. Actually, instead of taking a large steps, they are taking a small steps. They are trying to reach forward objects. So that's a reason, usually that's the major reason usually they fall when they're trying to catch the object. Okay, so they are taking a more small steps instead of taking a larger one. And the same time, actually when they reach the supporting surface, actually they are more aware and they are more ready to hold the object, but the response is very slow in geriatric population. So when they try to reach forward, that may lead a fall. So these are the three strategy what we have seen still now. The initial one, actually, when the force is very minimal, the subject is trying to gain a balance with ankle strategy. So here the force is very low, so he is not taking using his hip strategy. So only rely on his ankle strategy and trying to balance herself with ankle strategy. So the force is when a little bit more than the previous one. So the hip strategy coming to play. He is little bit bending forward and trying to regain her balance. So the force is little bit higher. She is taking a step forward to regain a balance. Here, he is trying to hold and catch when the force is little bit higher. So these are the strategies whenever we lose balance, and this strategy will help us to gaining the balance. So in the rehabilitation point of view, these things needs to be focused. So training ankle movement and training the hip, strengthening the hip muscles and stepping forward and backward. So these things will play a major role in training balanced in balanced training. So here we have completed three major objectives. One is the problem. Define the problem. We have defined the problem and delineating multiple interacting factor of the fall. And third one is the partial control and instability. And the fourth one is we are going to do a comprehensive assessment. And according to the assessment, we are going to giving the intervention. So how we can prevent the fall. The fourth and fifth one is a comprehensive assessment. Objectives are the comprehensive assessment, and according to the assessment, how we can prevent the fall. The comprehensive assessment, actually, research has largely, actually, according to the previous research, we have find various risk factor of the fall. So I can going to give a broad explanation why these factors are considered as a risk factor, and how we can examine these factors, and how we can how we can correct it, and how we can manage it with our therapeutic management. So the first one is the ankle range of motion. Ankle range of motion, especially once we are getting old, there is a limitation of dorsiflexion. So I can explain how it's the dorsiflexion is getting limited once it's get old. So the first risk factor for fall is the ankle range of motion.
And the second one is the flexibility. And third one is the balance. And the fourth one is the proprioception. And fifth one is the functional mobility. Actually, we have so many risk factors. So we have considered the previous evidence, and we find that these are the five major risk factors which produce often a risk factor for fall. So actually, first coming to the ankle range of motion. So why the ankle range of motion? Why the dorsiflexion is limited as we age? So usually we once we get age, decline in muscle strength with age. Actually, the muscle strength is going to decrease due to age. So that leads to decrease in size and number of muscle fibers. Once the strength has been, we have seen that actually the muscle bulk of the older people is very less. Okay, the size and number of fiber is going to less as we muscle fiber is less as we get old. And once the size and number of muscle fiber is coming down, the muscle shrink and loses its mass. So loses its mass, and once it loses its mass, decrease the water content of tendon. Actually, the tendon water content of the tendon is getting decreased. So once the water content of the tendon is decreased, joint motion is restricted and decreased. So actually, there is a lack of restriction. If you examine the patient more than 55, 60 years old, the ankle dorsiflexion, if you see 10 out of 8 or 7 definitely have a less ankle range of ankle dorsiflexion. So the reason is all this. And the decreased ankle range of motion, especially not only this plays a role, okay? So once the gastrocnemius is getting tightened, what would happen? So it brings the foot to plantar flexion. So the gastrocnemius, we all know, as a two joint muscle. So once it's getting tightened, automatically this tightness will reduce the ankle dorsiflexion. So gastrocnemius is a two joint muscle. So calf is the combine of gastrocnemius and soleus. So not only is limiting the ankle range of motion. So again, the proximal part of gastrocnemius is also getting tightened. So it's bringing a knee flexion, not only plantar flexion, reducing the dorsiflexion. It keep the knee in flexion once the dorsiflexion is limited. So what happens when walking? Actually, during walking and in the mid stand phase, we need a dorsiflexion to loading our body weight on standing leg. So we need a little bit dorsiflexion when we load during the stand phase of the leg. Okay. So because of reduced dorsiflexion, so the loading response to standing leg will not be happen. So the swing leg go very forward, actually soon forward to land, because this limiting motion of dorsiflexion will not allow us to load the body weight. So the swing leg goes forward and land immediately too fast. So if we keep on walking, if you see older people walk, they will not load the body weight. They can just walk with walking on the bed, or you can see that the loading response would be very low, especially the age above 65 or 70 years. The main reason is decreasing ankle dorsiflexion will not allow the subject to load. At the same time, when the load when the mid stand of the person is loading body weight, the knee should be straight. As I told you, the gastrocnemius tightness will not only reduce the dorsiflexion, it also produce the knee flexion. So definitely the body weight is not going to land on your foot. Instead of it relies more on your knee, as the knee is in the flex position. So most of the time, the prevention of fall is this increasing ankle range of, if you're increasing ankle range of motion, definitely there might be a lot of chances of preventing fall. So actually, we all know the musculotendinous junction most of the time, the stiffness happens on the musculotendinous junction. So if you keep doing a zigzag massage, like a zigzag massage over the calf, over the tendinoachilis, that will increase the dorsiflexion range. And stretching of the calf. When you stretch the calf, you can consider the plantar fascia. The hold, actually, you can hold the heel with your fingers, with curved fingers. So that will pull your calcaneum down. It will stretches the lower portion of gastrocnemius. And you can consider, actually, when you place your forearm pressure over the base of a great toe, will allow you to stretch plantar fascia along with your calf muscle. So the calf is the two joint muscle. So when you keep a knee in extension, as a complete extension, when you stretch, as a stretch goes to the gastrocnemius. Okay. When you keep a knee in flexion and you stretch, if you do the dorsiflexion, is completely stretched to the soleus. I means to say the gastrocnemius is the two joint muscle. It originates from the condyles of femur, and it will get inserted in your calcaneum. So the muscle needs to get, the two joint muscle needs to get stretched in both joints. So stretching a gastrocnemius is highly focused with the extension of knee along with dorsiflexion. Will increase the range of ankle dorsiflexion. So at the same time, muscle is get stretched with multi-directional. So for example, this may allow to the muscle to stretch the lower portion, the lower part of distal part of the muscle is getting a good stretch when you do a dorsiflexion. The proximal part, if you want to stretch the proximal part, you have to stabilize the ankle. And if you keep moving your knee up and down on the line, so the proximal part of the gastrocnemius is getting stretched, as the distal part is already stretched and hold. So the proximal part can be stabilized or can stretch with moving a knee up and down. So this will increase terminal extension of knee. So usually, as I told, the calf is the two joint muscle, which will limit your dorsiflexion as well as the knee extension, the terminal knee extension. So the weight shifting mechanism will not allow you to load on your foot. The weight will not go to your foot as the knee is in flex position. So this stretch will increase the range of knee extension, that is a terminal extension, which is mainly mandatory during the stance phase of walking. So that's all about the ankle range of motion. Actually, we have seen the ankle range of motion, how it's affect, especially how its contribution is for, how we can check ankle range of motion, and what way we can increase the ankle dorsiflexion. The second major risk factor is the flexibility. So actually, how the flexibility is contributing for falls. Decreasing ankle range. Actually, I told, actually, we have the previous topic. Actually, we have seen the ankle range of motion is reduced due to age. So once the ankle range of motion is reduced, especially dorsiflexion, so as I told you, decreased knee extension, the terminal knee extension is also reduced. That may lead to fixed flexion deformity. So fixed flexion deformity, the person may walk with minimal knee flexion. So the person, the terminal knee extension is not possible, and the person keep walking with a slight knee flexion. The flexion deformity. So once the knee is, the person is keep on walking with flexed knee, automatically the composite reaction happening on the hip is also getting flexed. Okay, so that will decrease the flexibility of hamstring, gluteal, as well as the gastrocnemius. See here, actually, So the gastrocnemius tightness will reduce the dorsiflexion. As I told you, there's a two joint muscle. It's also tighten the knee. So the knee flexion, this tightness will not allow the knee to extend terminally. So the person may walk with knee flexion. So this action is going to produce with a compensatory hip flexion. So these all things, the old age gait automatically change to propulsive gait. Actually, the hip flexion, knee flexion, and so limited dorsiflexion. So the patient automatically, because of this, the trunk may lean forward to regain the center of gravity within the base of support. So this is the way the flexibility affected once we get old. So how we can assess the flexibility? So we can assess the hamstring flexibility with sit and reach test. This is the box which has the measurement over in it. The subject has to keep the foot neutral position and can reach as much as they can. And score of the fingertip over the ruler can be measured. So as I told you, so if you ask the subject to sit on the couch, the terminal knee extension is going to be affected because of two reasons. One is maybe a major a reason of gastrocnemius tightness, or maybe the hamstring tightness. So the terminal knee extension is not possible. If you ask the subject to sit on a long sitting position, so you may feel the 5 to 10 degree of knee flexion, which the posterior aspect of the knee is not going to settle down with the couch, settle down in the couch. We can think that the subject may have a 5 degrees of fixed flexion deformity. So the stretching of hamstring along with the gluteal facial stretch of gastrocnemius will give a good results. See here, actually, if the subject is asking to hold the finger with a repeated knee extension and flexion, will improve the knee extension, and it also increases the hamstring. It can stretch all these muscles and the posterior, your paraspinal, gluteal, hamstring, as well as your calf. So as a complete a facial stretch, which may bring back the terminal extension of knee. That will, so once the terminal extension of knee is happening, so there's the subject can walk with good loading response when the mid stance phase. So that's all about the flexibility. And third risk factor we have here is the balance. So how the balance is affected in so once we become old. So as we previous topic, we have seen how the flexibility is decreased. Okay, so the flexibility is, once the flexibility is decreased, the body is going for altered movement pattern. There is no normal movement pattern. So because of the decreased flexibility, the body may have some alteration. So that compensatory activity of hip trunk, okay, that alter movement may produce a compensatory activity. So the person may lean forward or to maintain his balance. So once they lean forward, automatically the partial control get decreased. So the partial control decreases, and so once the partial control is decreased, so that leads to compromising in balance. So we don't have a good partial control. Definitely, we can't walk with a good balance. So that in this way, the balance is affected because of age. So usually the balance can be assessed with various scales. Actually, here I have mentioned the Beck balance scale. So here the Beck balance scale measure ability to perform several common daily activities in living tasks safely. It has a maximum score of 56. Higher score indicate a lower risk of falling. Higher score indicate lower risk of falling, and lower score indicate high risk of falling. If the person score, a Beck balance score is high, they have a very low risk of falling. If the person's Beck balance score is low, they have a high risk of falling. So how we can train the balance? Marching over the stepper, or marching with the feedback of keeping a hand on his pelvis and giving a feedback of his hip position. So forward march or a backward lift or a side leg lift. So these all the areas where we can improve the forward and backward balance. And the last two thing is the proprioception and functional mobility. So how the proprioception is getting reduced, how it would be one of the risk factor when we get old, how it's a risk factor to fall. So as we know, actually the balance has been compromised because of altered movement pattern. So once the balance has been compromised, the decreased balance control affect the functional mobility. So once the balances are getting affected, your functional movement, the daily activity is going to be affected because of you have a minimal balance. So altered neuromuscular control, this leads to altered neuromuscular control and poor balance, decreased proprioception. Okay. So once the functional mobility is decreased, altered neuromuscular control, the neuromuscular control is going to be get altered, and the poor balance decrease the proprioception. Due to the poor balance, the proprioception also getting down. So all this contributing factor increase the risk of incidence of harmful fall. As I told, ankle range of motion, balance, proprioception, flexibility. So these all the risk factor. It has interlinked with each other. So in this way, so one affect others, and finally all this contributing factor lead an incident of harmful fall. So how we can test the functional mobility is a time up and go test. Actually, one of the tests available is a time up and go test. So in this test, the time seconds taken to complete the task is measured. So when the subject is rising from the chair and walking 10 feet, turning around, walking back and sitting on the chair. So to complete this activity, the time has been measured. The time has been taken to complete this activity. We can check with pre and post intervention. That is before our intervention, what the time taken to complete this task. And we can give the balance activity and improve the functional mobility with the sitting and rising. And we can measure back with the score again. And that will say how the subject is getting improved. So especially most of the fall happening when rising from the chair. So we can train it sitting and rising from the chair with the knees at 90 degree. That will give a lot of confidence when rising from a low level chair. You can start initially with a little bit height, and then we can reduce the height further to get a more control on your knees. And the proprioception has been measured with a lower limb matching test. Here, the seated subject has been here. The subject has been sitting position. The archaic sheet has been placed in between two legs. This archaic sheet has been marked with a protector. So with the closed eyes, a subject has to match as two grade 2. As the match to grade 2. So usually the difference between the difference of matching. So if they have if they match, there is a difference in both sides of matching has been taken in the degrees. So this degree is given when there is a larger difference of degree matching grade 2s. If there is a larger difference, that will say that there is a lack of proprioception. So how we can train the proprioception? As I told, three major system contributing for balance control, three major sensory input, vestibular, visual, and proprioceptive. Okay. So once you block the vision, okay, if you give any activity while blocking the vision, so definitely the other two system is getting engaged more. So your vestibular system and the proprioception is getting engaged more. That will keep training your proprioceptive, especially joint sense. So training on the foam surface will increase the proprioception. So the same thing, single leg stance or weight shifting on the foam surface with open eye, going to engage your vestibular system initially. So in the same thing, to see how she is struggling while closing her eyes. So once the closing her eyes, we are blocking the vision. That helps to balance yourself on the space. So your body entirely rely on your proprioception and vestibular sense. Okay, so this two system will only contribute for balance. That's why it's a little bit hard when we stand with the closed eyes. Okay, so we have completed all the five major objects. We have seen, we have defined the problem of falls and delineating the multiple interacting factors in fall. So we have seen the role of postural control in instability. And the last thing, we have made a comprehensive assessment and we have given a principle of intervention. Okay, so these are the major five objectives we have discussed today. And the last thing is, so I actually initially I have given a history of patient that why my right knee is only paining, why my right knee is only getting older. Okay, so it's osteoarthritis. Actually, the degenerative disease, not only because of your we are getting old. It's not only because of we are getting old. So as I told you, these all the contributing factors, the risk factors, the balance, and proprioception, ankle range of motion. These are the contributing factors once we get for fall, once we get old. So as I given a brief explanation, the incident of harmful fall. Okay, once the incident of harmful fall is increases. Okay, think that the person is getting fall or the person is getting altered movement. So that will make abnormal joint mechanics during functional activities. Okay, so that is the abnormal joint biomechanics. For example, walking with the knee flexion, walking with the limited dorsiflexion, walking with hip flexion, walking with the trunk forward position. Okay, these are the abnormal joint biomechanics happening because of all these factors. Okay, so this will increase the arthritic changes because the joint, whenever the joint is a joint or the bone is moving, deviating from the normal biomechanics, there is an increased load to the joint as well as the distal and proximal joints. Okay, there is some order biomechanics. So due to the order biomechanics, that's why we have a genu valgum in once we are getting old. Okay, there is alter biomechanics when we do we continue the daily activities, we continue walking with alter biomechanics, that may lead increasing load on one joint, especially maybe a knee or ankle. That might be the reason for arthritis of right knee. So this might be the one of the reason why my right knee is only getting old. It's not getting old, it goes for degeneration because of altered movement pattern. So implementation, finally the implementation of this topic is actually, so whenever you attend a geriatric patient, okay, so just ask a single question: have you ever been fallen? Okay, so you have ever been fallen? If they say yes, okay, so the rehabilitation program, you know the risk factor of the falls and how it's contribute contribute towards the fall. Okay, for example, balance followed with functional mobility, dorsiflexion, flexibility, proprioception, and plantar flexion. Okay, so the plantar flexion is the least cost. Actually, there is a plantar flexion is nothing is contributing towards the fall, but all other five variables is actually the study states, according to the evidence, all the other five variables have a major role in falls. Okay, so simple balancing exercise with the functional mobility exercise and some amount of activity that will increase the dorsal flexion and flexibility, and some proprioception exercise will definitely going to make the geriatric people free from falls. Okay, so if you attend the patient with periarthritis shoulder or osteoarthritis, there is no matter. Okay, if you ask the question if the patient has ever been fallen, so just adding simple stretching exercise for ankle and simple balancing exercise will prevent further fall in geriatric population. So all this intervention make a fall-free world. Thank you for giving this opportunity. Thank you so much.
Thank you, sir. Thank you so much for a wonderful session. And even work balance scale itself is a 2 days topic. A lot of things, strategy, all those things for 2 days. But you just put it everything in a nutshell. And I would like to thank my sister, Dr. Priyadashini, who is watching this session in YouTube. I tried a lot to get her into the session, but her Zoom link is not connecting due to poor network. Thank you, Priya. Actually, she's the one who guided me to start a YouTube channel, and I hope you are watching now also. Thank you so much, and thank you, sir. Thank you, Ramesh sir, for helping us to run the show so smoothly. And I thank Dr. M. Sendil Kumar from Salem, senior most physiotherapist, for joining with us. He's also there. And let us move on to question and answer session. There were so many questions. Good evening, sir. Good evening, Sendil sir. Yes, sir. Yes, sir.
Unmute, sir.
Sir, very good evening, sir.
Unmute your mic,
Sir,
sir.
unmute and talk, sir.
Unmute your mic, sir. Yeah.
Yes, sir.
Very good evening. Very good evening to all. Very excellent presentation. The topic is related to research topic. So that's why from the beginning I should attend the classes. Very well, sir. Very excellent presentation.
Thank you, sir.
Thank you, sir. Thank you so much, sir. We will move on to the question and answer session. The first question is from Dr. Ria. Sir, please explain lower limb matching test.
So 1 second. Actually, in the lower limb matching test, the sheet has been placed. Actually, the archaic sheet has been placed in between the lower limb of the subject. Okay, so just I will take the picture. You can understand a little bit clearly. So the sheet has been inscribed with actually they have a marking with a protector. Actually, we have a drawing the lines like a protector.
Sir, you want to share screen?
Share, please allow me to share the screen.
Yeah. Sir, you can now.
Yeah, sure. See here, the subject has been high sitting position. Okay. This is the archaic sheet. It's inscribed. Actually, we have a marking like a protector. Okay. This sheet has been placed in between her leg, especially from the knee to ankle. Actually, this is the lateral view of the subject. Okay. The sheet has been placed. The corner of the sheet has been placed on in between her knees, and ask the subject to match actually with closed eyes. Actually, the subject needs to close her eyes and ask the subject to match the great toe, because either side of the sheet has great toe, left and right great toe. Ask the subject to match the great toe. Once we see actually if there is a proprioception lack, this matching will not in this way. Okay, so that would be a little bit different from the right and left. Okay, so in between the sheet, okay, if you take the sheet, in between the sheet, there would be a little bit a difference between the right and left. So this different is taken as a degree, as a form of a degree, so 10 degree or 8 degree or 7 degrees. The difference between the two sides, the right and left toe, that reading has been taken as a degree. So that is considered as a proprioception lack. If there is a increased difference, so for example, 20 degrees of difference between right and left toes, so we can consider that is a more proprioception lack. Okay, if the degree is a little coming down, they have a proprioception, good proprioception. If they match perfectly, the proprioception is good. So this is it's called a lower limb matching test. Actually the point of grade toe has been taken for consideration to measurement.
Thank you, sir. We will go to the next question. Duna madam, kindly check if there is any question in YouTube.
Sir, there is no question in YouTube, but a question in chat box, sir. Please read it out.
Yes, madam. Sure. The question from Amulya Datta from Assam. Sir, what appliances is mandatory or we should fix in our offices, clinics, home, etc. for senior citizens to reduce the fall?
Sir, would you please repeat the question?
Yes, sir. What appliances is mandatory or we should fix in our offices, clinics, home, etc. for senior citizens to reduce the fall?
Actually, that is coming under the ecological factor, actually environmental factors. So especially giving a ramp or the rails, rails, actually those things, actually if I taken as a completely, so it goes for another day. Actually, I just want to give a management of physiological problem, musculoskeletal problem, which we come across. So especially if you think of as an environmental factor, the height of sitting stool is very, very important. And the way the rails has been the rails, or we should have a more space moving walker, and they should have because they feel actually they feel congested, they have a problem of falling again. Actually, they always have a tendency to reach. So that reach is actually they are more ready to reach. Actually, I've given one of the example when we talk about the strategy. For more than adult, they are more ready whenever they are trying to hold. The older peoples are more aware of trying to hold, but the response is slow. Once we get age, the response is very slow. So once reaching object, they feel that they have reached already. When they try to reach, they fall again. Okay, so the rails and the moving surfaces, I feel is more convenient to avoid fall, especially a slippery surface and the height of the chair. How they getting, because once the height is very low, they have a difficulties of getting up from the chair. So those things play a role, especially when we talk about the ecological factor.
Thank you, sir. And thank you so much for wonderful explanation from Dr. Ria for your answer to her question. And there are so many appreciations, and thanks a lot for explaining well the biomechanics part. Thanks, Dr. Vadivelan, sir, super explanation. Thank you, sir, for good session. My question from Pavi, what are the various age groups? And we are giving balance training. How many repetitions was given to geriatric group?
So here the repetition is actually, I feel it doesn't matter. The repetition, we can't restrict with the repetition. Okay. So as a therapist, if you're starting the rehabilitation program, you should not strain the patient. So if they perform with initially, the movement pattern should be kept in mind, because we know how the movement is happening and what are the muscles, how the balance is contribution. We know all the biomechanics. But as the patient point of view, if you're seeing that they doesn't know so the movement pattern, all these things, they only know, they do what you taught to them, what you taught to them. Okay, so on the time, the learning the movement pattern will take a time. So if you focus the repetition, if you are giving a 10 repetition, do this with the wrong movement pattern is not going to help. Okay, so the learning movement pattern initially may have a minimal repetition and the correction needed. Once the movement pattern has been corrected, and the repetition will not strain the knee, especially when you giving a balance training. The repetitions will not strain the subject. Okay, so it's highly depend on the subject, you can analyze the facial reaction of the subject, and you can think of the subject inability when they perform more than 6 or 7 repetition. You can stop over that. Okay, so the repetition and the program is highly individualized. Okay, you can modify your repetition, you can modify your exercise program according to the individual, whichever the easiest things come first. Once the subject is getting trained, you can progress, because the exercise is not kept on the same level. So if you can progress further, definitely that progression is going to be help. If instead of gradual progression, if you are giving 10 repetition, if you're focusing thing, actually I have to give a 10 repetition or 15 repetition. If you focus the repetition, maybe after 8 or 9 repetition, he may have a compensatory activity of other joint because of the inability, that may going to deteriorate his or her balance further. So don't think of the point of repetition, think in the point of individualization. So every exercise program should be individualized according to the subject need.
Oh, yes, sir. Thank you, sir. Thank you so much. We'll go back to the next question. From Dr. Vijay Lakshmi from Karnataka, the effectively of counseling in preventing falls. So she is asking about what is the effectiveness of counseling in preventing falls.
Counseling, actually, so you should so take a assessment of fall. There is the onset of the fall, when it's happening, where it's happening. So whether it's a time of fall, whether it's in the morning time, usually when they have a work or going out of home, and they usually have an urge of doing activities that may lead the fall. So before you counsel the geriatric people, you should have a proper history of fall and the fear of falling. We can measure the fear of fall with VAS. Okay, for example, if you give us, this is a completely fear of fall is like a pain, as a completely subjective scale. We have a questionnaire. So as measuring with proprioception or ankle range of motion, it's not objective type of measurement. Even you can measure fear of fall with VAS. For example, giving a score of high risk of fear of falling, having a high risk of fear of falling with as a 10. So no fear of falling as a 0. You can ask him to mark it down. Okay, so according to that, you can counsel him, counsel the subject. Okay, so again, so when it's falling happening in the home environment, definitely, as I told you, is going to be a severe problem, because it's the used environment. Of the fall happening in the used environment, there might be a severe problem with the subject. Okay, so all this information, you can counsel the patient what the changes can be done at the home, as well as the exercise program, as well as the time of fall. Those things need consideration, taken for consideration.
Okay, sir. Thank you, sir. And yes, a lot of appreciation, sir. And from our Ramesh sir also. Thank you, sir. Thank you, Ramesh sir. Yes, Duna madam, once you check if there is any questions in YouTube, we can read it out. Otherwise, we can conclude it.
Just check, sir. No question is in YouTube. And
Yeah, okay.
only appreciations are there.
Yes, okay, madam. Thank you, sir. Thank you, Dr. Vadivelan, for a wonderful session today. And hope even after setting the world record, we will be having your sessions. And you keep teaching us, and we will keep on learning from you. And I thank all our participants in the Zoom meeting, and also from viewers from Fitness and Rehab India YouTube channel. Very much thank you. And I thank EXRX India team members, Dr. Rupesh and Professor Duna, for all of you. Thank you so much. Good night.
Sir, thank you for giving me this opportunity. And thank you once again. I wish you all success for EXRX Team India. Thank you.
Yes, sir. I would like to thank Dr. Mohana Krishnan also for guiding to reach you. And it's a wonderful journey for more than 200 episodes. He recommended many resource persons for me. By his help, also I have reached this much. I should thank him. And thank you,
Sure.
Mohan Krishnan sir. Hope you will watch this one day. Thank you, sir. Thank you all. Bye-bye. Good night.
Good night, sir. Thank you.
Good night.
Yes, sir.